Aortic dissection usually results from long-standing hypertension. The inner layers or tunica of the aorta tear. It usually starts out as a little tear, but with continued hypotension and pulsation waves from the beating heart, it continues to tear. You may have heard me say that a cardiovascular surgeon once told me that the aortic tissue is like a wicker chair. Once you get a little tear, the tissue continues to break and unravel. As the dissection grows, perfusion through the aorta changes from a single laminar pulsation through the vessel to different dissected parts of the aorta called lumens that are perfusing different parts of the body. You should be thinking about an aortic problem when you have two or more body systems involved, like shortness of breath with a single leg being numb, or stroke symptoms with chest pain. One of my pet peeves is this emphasis on 12-lead EKGs for stroke patients that some systems have laid into the protocols. The thought is that if there is an embolic event that caused a stroke, then theoretically there could be a clot in the coronary arteries. The occurrence of an ischemic stroke and a simultaneous myocardial infarction are literally a fraction of 0.1%. There are no EKG changes that are associated with aortic dissection. The EKG could look absolutely horrific, or the EKG could look perfectly normal. If the patient presents with cardiac symptoms plus stroke symptoms, aortic dissection should be very high on your list of differentials. As far as dissection, 3 things critically important, very, very important to know. Pain control. You gotta aggressively treat these patients' pain. You can give all the beta blockade in the world, but if the patient is experiencing excruciating pain, it's like pissing into the wind with your beta blockade. Then the priority is impulse control, reducing the amount of heart beats. If I have a weak, flimsy door and someone is kicking on the door 120 times a minute, the door is going to be less at risk for bursting apart. If I can reduce the amount of kicks, then they need aggressive blood pressure management. You don't want them higher than 120 millimeters systolic. 90 to 100 systolic is fine. If they are hypotensive and they have a dissection, they are dying. I'm not saying that they're a dead man walking. Actually, they kind of are a dead man walking.